So let's move on to more immune-based treatment. So this topic is allergen-specific immunotherapy for respiratory allergies. I'm going to limit the talk discussion to respiratory allergy, meaning asthma, allergic rhinitis, and conjunctivitis. I will not cover anything about oral immunotherapy for food allergy, for example. So as we know from this ISAC study has been published more than 10 years ago, there's a heavy burden of different respiratory allergic diseases such as asthma, allergic rhinitis, and rhinal conjunctivitis in our region, especially in children. So for asthma in Hong Kong, it's about 1/10 of our secondary school children, and currently, and rhinal conjunctivitis is especially important in locality as a very as a comorbid respiratory allergy in patients in children with asthma. So about a quarter to up to even 1/3 of our local school children have allergic rhinal conjunctivitis. These immune mechanisms underlying the T2 allergies. So for majority of our pediatric patients of asthma and rhinitis, they are more the T2 type, meaning the Th2 cytokines of increase in the IL-4, IL-13, and also IL-5, and clinically driven by eosinophil-based phenotypes. So with this scheme, we have a number of different initiators or triggers. Of course, we have allergens on one hand, the dust mites, and also pollens and danders from furry animals. And also we have the pathogens, the microbes such as virus and bacteria that actually damage the airway epithelial cells. So with this damage, we trigger a number of different epithelium-derived cytokines such as TSLP, IL-25, and IL-33. These are very important drivers of subsequent events that actually activates the innate lymphoid cell type 2 and dendritic cells to then drive the airway inflammation towards the Th2 cytokines. And these also interact with the subsequent adaptive immune system of different cells, and also with the early cells involved in early mediators, such as the mast cells and basophils, to trigger further augmentation of this cascade. So there's a very complicated cascade, basically, but then just to remember for children, the Th2 is a very important part of this type 2 allergic disease. Of course, we discussed about this area. This is true for allergic rhinitis, and also in principle, same for asthma, that we have the allergen avoidance as a very important part of the management of these patients with respiratory allergies. And then we have the pharmacotherapy. With pharmacotherapy, of course, we have to select the most important, most appropriate treatment. And don't forget that we need to optimize the techniques and also ensure the adherence of patients to different pharmacotherapy. And education, again, is very important. But then even a number more unique to our allergy field will be the immunotherapy. That hopefully will drive the sort of immune skewed from Th2 to more the Th1 or the more balanced pathways that actually restore all the immune homeostasis in the airway. So an evolution of immunotherapy is actually a long history. It's not something that's new. It's actually back in 1910, so 115 years ago, we have the first documentation of the grass pollen immunotherapy, injection subcutaneous immunotherapy. So about 60, 70 years ago, we have the double-blind placebo control clinical trials with the immunotherapy, and subsequently, about 1960s, we have the sublingual form. Of course, the initial phase has not been that successful. So slow development for some of these clinical trials, but then the grass tablet immunotherapy, especially sublingual form, was devised about 20 years ago. So right now we are actually entering a era that we have lots of different modalities of immunotherapy that we can choose. Basically, the diseases that we have good data on using immunotherapy will be the pollens. For example, in the Caucasian in the overseas population in the pollen season or before pollen season, we can actually start patients on immunotherapy that actually help them to tide over the typical pollen seasons that they frequently experience symptoms. And we have the immunotherapy, we have the cat, dog, and especially in Hong Kong, at least 9 out of 10 of our children and adults with the asthma, they have the sensitizations to house dust mite. So it's a very important part of our daily counseling and daily assessment. And also, of course, the bee sting and other kind of venom-induced allergies. So these are the sort of target these allergens that we frequently discuss with patients for the immunotherapy use. So how immunotherapy works? So this is the actually lateral exposure. So area exposed to, for example, dust mite and cats, there is a sort of lateral exposure in form of low-grade, low-dose exposure. And with the antigen-presenting cells, it actually drives the body towards the more Th2 inflammation, so production of IL-4 and IL-5, that actually result in allergic manifestations. But immunotherapy, hopefully, is a kind of high dose allergen exposures of the body or to these allergens. And with this high dose exposure, the immune processing is different. So it actually goes through the antigen-presenting cells, and then it tends to increase the regulatory T cells, and that secrete the IL-10 and TGF-beta. And also, some of these high dose exposure also directly cause the Th1 stimulation. With this stimulation of the allergen immunotherapy stimulating the regulatory T cells, IL-10, and also tolerogenic dendritic cells. Subsequently, it will act also on other parts of the adaptive immune system of the other dendritic cells, type 2 immune lymphoid cells, and also tends to inhibit the Th2 cells and increase the Th1. And also it acts on other cells such as basophil and mast cells. So subsequent to the regulatory T cells, it basically will more restore the homeostasis of the immunological derangements seen in the airway. Apart from that, adaptive immune system immunotherapy also result in rapid desensitizations and dampening of the activated mast cells and basophils. So they would not release that much mediators such as histamine and other harmful immune mediators in the airway. And the immunotherapy would also result in some innate immune regulation in the form of like it would inhibit the type 2 innate lymphoid cells and also would restore the monocyte and dendritic cell numbers. So these are sort of some of the mechanisms that underlie the successful allergen-specific immunotherapy. Clinically, what we observe is that very early on, after the start of immunotherapy, more the injection form, we really study the cells, whether the blood will result in the very early basophil tolerance. And then about several weeks later, we'll start to see the increase in the regulatory T cells. And we study more about the IgE, then it actually would change not that quickly. So about several months, so 3 to 4 months later, we'll start to have the decrease in the allergen-specific IgE, and also the type 1, the skin test, also start to decrease only about 6 months after the start of immunotherapy. So chemically, it has a very early onset, but then if we actually follow patients with the blood test for specific IgE and the skin prick test, we can only observe the obvious difference several months after the start of immunotherapy. So with different forms of immunotherapy, on the left side is more the injection form. Usually, just one example that typically we have the initiation kit that we have the increasing dose of these immunotherapy vials with 1, 2, 3, for example, 1 to 4, that shows the increasing concentration of different of allergens inside the vial. And then we will give increasing dose of that vial in one time, and then so if one finish with the patient tolerate the first few dose of vial 1, we move to vial 2. So basically the concept is to keep increasing amounts of that allergens to the body until we reach the maintenance phase that patient can tolerate the maximum. of the, for example, vial 4 in this example. And then we'll sort of change to the maintenance phase that we keep the same vial 4 and continue for whole duration of usually 3 years. On the left side is an injection form subcutaneous. On the right side is more the sublingual. So you can see from figures that actually we have different, more high variety of different sublingual preparations. Some are the sort of single vials that we have a solution form that we put underneath the tongue. And we have also the spray, that 2 different spray that actually we can actually put underneath the tongue, also in the swab solution. More recently, we have the tablet form that we can actually ask the patients to actually put 1 pill of the immunotherapy underneath the tongue. And that actually have a quite fast dissolving kind of technology that within seconds, the pill will just dissolve underneath the tongue. So then we have more recently, because of more environmental friendly, the company actually moved from single vials to the reusable larger vials that patients have to actually use a syringe to withdraw the amount, so to put underneath the tongue every day. So basically the concept for sublingual immunotherapy would be to use it every day. For subcutaneous is to give the injection every few weeks. So there are pros and cons, of course, from the patient's perspective. One patient need to have received a needle injection, so that's not that friendly for children. But then it saves the trouble of using it every day. So for some patients who are busy or some adolescents who may not actually sleep that regularly at night time, so sometimes they may forget, especially when they're actually getting better control, they'll just forget, just like any patients who have chronic illness. When they feel better, they tend to use less drug. So sublingual, this kind of problem, but then of course, it's safe to worry about having the injections at certain intervals. So each have the pros and cons. Of course, cost is about roughly similar, I would say, right? So mainly we discuss about with the patient about the lifestyle, about the preference, and also the parents, or especially for children, whether they actually can supervise. Otherwise, for adolescents without any supervision, most of them will just forget this sublingual. So apart from that, so what is the evidence, scientific evidence about these 2 modality? So the upper part is the subcutaneous immunotherapy. The lower part is the sublingual. And usually we assess for rhinitis in form of symptom score and medication scores. And for both the subcutaneous and sublingual immunotherapy, we have good evidence that actually this meta-analysis favors the use of immunotherapy to reduce the symptoms of asthma, and also in other meta-analysis, the rhinitis. And on the right side, the medication also, they use less medications after the use of this immunotherapy. Here's another meta-analysis comparing the with this, subcutaneous injection immunotherapy of control definitely is favor the immunotherapy. Comparing between injection and sublingual, I think this is a very controversial topic and quite high sort of concern from our colleagues. In general, some meta-analysis actually shows that they are similar. As in this one, it did not actually show any significant difference in terms of like the symptom score after use of pulse-axis immunotherapy for rhinitis between injection and sublingual form. And for the medication score, it also favored, like for the sensitivity analysis, for the forest plot, that actually use of subcutaneous immunotherapy with the pulse-axis actually shows that it's actually allow patient to be better control for their rhinitis and to use less medications. This head-to-head, so there are actually not that many head-to-head clinical trials comparing between subcutaneous and sublingual. Sorry for the sort of small typo, but just to show that actually this column with the symptom and medication score, in general, the subcutaneous form, the injection form, have a slightly better effect on the improving the symptom and medication scores as compared to the sublingual. But then some trials, of course, these are relatively small trials, actually do not find any significant difference. So in general, you can say subcutaneous is slightly more better in form of the reducing the symptoms and medications. And there are also some newer data that suggesting that immunotherapy actually has result in prevention of asthma. So this one, there's a randomized controlled trials, the meta-analysis, and it shows that actually at the lower part, the random effects model that immunotherapy prevented the development of asthma in these patients. But then there are certain factors that actually help us to decide to predict which one will benefit. So in general, the children respond better in terms of the asthma prevention of the immunotherapy. And the other is the monosensitized. So it's not good if the patient is sensitized to like house dust mite, cats, or mold. So they are polysensitized, they tend not to derive that much from the benefit. And 3 years of therapy. So some previous data suggested that comparing between like 2 years, 3 years, and or even as short as one year. Definitely 3 years has a superior benefit in terms of the clinical benefits compared to 2 years. So usually we advocate patients to maintain on the either injection or the sublingual form of immunotherapy for at least 3 years. So how safe is immunotherapy? I think this is so far the most important surveillance from Europe. So these are kind of network that actually survey about allergen-specific immunotherapy related anaphylaxis. And out of the more than 15,000 in patients with the anaphylaxis case, they actually look into whether they receive immunotherapy. About 1.1% of these patients actually have the allergen-specific immunotherapy-induced anaphylaxis, so 1%. And most of them are related to injection form subcutaneous immunotherapy. Only 8 of these patients cases have the anaphylaxis through the sublingual immunotherapy. So by far, I think subcutaneous immunotherapy is much more varying in terms of the inducing anaphylaxis as compared to sublingual. So that's also the reason why we usually advocate patients to carry an adrenaline auto-injector when they actually choose the form of subcutaneous immunotherapy. Whereas many international guidelines do not actually support the need for patients with sublingual immunotherapy to carry that auto-injector because of the much better safety profile. And for the anaphylaxis, about half of them are adults and half are children. And then with the long allergens that the patient underwent the immunotherapy, pollens is one thing accounts of more patients with AIT-induced anaphylaxis, and house dust mite and rhinums are the others. So subgroup analysis in form of like the children and adolescents as compared to adults. Children and adolescents tends to have more respiratory type of anaphylaxis, so wheezing and breathing difficulty. Whereas adults, they tend to have more cardiovascular and GI-related anaphylaxis. So these are sort of slightly different expectation or the kind of monitoring that we need to offer for patients who undergo this especially subcutaneous immunotherapy. In form of like the which kind of allergens will trigger anaphylaxis in this patient. In general, for adults, it's more the venom induced anaphylaxis in the patients. But for children, there's more the house dust mite, right? So house dust mite usually experience that children tends not to have that many venom-related allergy. And pollens as well, especially in Hong Kong, we don't see a high burden of hay fever or pollen-induced respiratory allergy. So children, most of them receive dust mite in our locality, and then so dust mite in children will be particular concern in terms of like monitoring for anaphylaxis. So in general, how to choose between subcutaneous or sublingual depends on the efficacy and also safety. Of course, this is a general principle in medicine. So for efficacy, of course, we have to select the correct allergens, not only by the skin prick test. So skin test may not be directly relevant in terms of like attributing the exposure to the symptoms. Of course, in the history, we have to ask whether the patient is exposed to certain allergen, whether they develop symptoms. Sometimes the sort of mildly positive sensitization may not be that relevant to a particular individual, and so we don't automatically, once they have the positive skin prick test, they choose certain immunotherapy. That's not the usual approach. So we need additional information. So safety in terms of LEUNG is much safer than compared to the injection form. We have the newer choice, such as the Allergen, and the presence of asthma would be another concern, especially with patients with immunotherapy, because asthma tends to increase the likelihood that these patients develop respiratory adverse events after the start of immunotherapy. So the real-world effectiveness is a kind of retrospective cohort in this study, assessing over 11 years about the prescription, and also the matching about AIT versus those of controls. What they find is that over the 9-year surveillance period, so all YT group result in less prescriptions for the allergic rhinitis after the use of the immunotherapy. For subgroups, the AIT result in better or more asthma treatment step down, and also less severe asthma exacerbations, as well as asthma-related hospitalization as compared to the control group without any AIT. And whereas it did not actually result in any change in pneumonia diagnosis. So it's quite specific to the airway. So a summary for the long term, so study of the subcutaneous grass-pollen immunotherapy showed the disease modifications and long-term efficacy. So basically, clinical trials support the use of these form of immunotherapy, but then for treatment for at least 3 years. So immunotherapy is out of all the modalities like pharmacotherapy, is the currently only medical interventions that alter the natural history. So this is how we actually select patients. Of course, the first is where there's any evidence of allergy sensitization and symptom consistent with the allergen exposures. And then we have to assess for the risk-benefit. Like immunotherapy, currently we consider that for those patients older than or at least 5 years of age. For younger, they may not be that able to express their adverse events, and they may not become that adherent to the treatment. So for positive for OIT, we need the adequate communication with the children and the parents about the adherence, the protocols, and then we also, after we start the AIT, with the regular reassessment about adherence, about the benefit and side effects, and other assessment profile. So this is how we actually proceed with our selection of AIT. For the guidelines, just a highlight for the allergic rhinoconjunctivitis from Yaki guideline. Best of AIT should be considered for those with symptoms suggestive of rhinitis and conjunctivitis, evidence of IgE either by blood tests or the skin prick test, and the moderate to severe symptoms despite regular treatment. So this is again very important. We don't usually start immunotherapy right away without patient being optimized for the treatment. So at least we see that they are being treated with the usually first or second line, and then they are still not that responsive or refractory. And also we need the families to be quite compliant with the avoidance strategies for the relevant allergens. And then patients who are polysensitized to taxonomically related allergens can select a single allergen or mixture of homogeneous allergens. So dust mite with different dust mites, then we may combine them. But then to polysensitize to non-homologous allergens such as cat and dog and for example mold, and then we have to discuss with patients, right? So especially on which allergen would account for most of the symptoms. So if we tend to start only single allergen immunotherapy in patients unless they actually have the various troublesome symptoms from different allergens at the same time. So for the area guideline, immunotherapy is used for most patients, mainly for those of mild persistent and moderate severe persistent eczema, so rhinitis. So meaning they have really daily symptoms that sometimes trouble them for the daily activities they sleep. So there's a candidate. For asthma, the GINA guideline, actually have a role that actually we tend to use house-customized sublingual immunotherapy for patients who are actually belonging to step 2 and to 4. For patients who are not poorly controlled for their asthma, we tend not to start them on immunotherapy because of the adverse event, especially for the agenda guideline, the injection form subcutaneous immunotherapy, we tend to not use that for asthma. So they at least have to get the asthma under good control first before they consider candidates for injection form. But for sublingual, because of better safety profile, then they may consider candidates for sublingual immunotherapy for dust mites. Contraindications, these are absolute contraindications, uncontrolled or severe asthma, the active severe systemic autoimmune disease disorders, active malignant neoplasm, and poor adherence to our usual standard treatment for the rhinitis or asthma. So the others are relative contraindication only. So asthma prevention, so a 3-year course, again, either the sublingual or subcutaneous form, we will consider patients with moderate to severe viral conjunctivitis, to pollen's allergy, not sufficiently controlled with optimal pharmacotherapy. So I think that's more restrictive, right? So to either prevent the onset of asthma or additional sensitizations and to better control the viral conjunctivitis. So these are some evidence on this aspect. So new forms of neurodevelopment in AIT, we have the some low-flow treatment of the epicutaneous and also intralymphoid type of immunotherapy, and we can also modify the allergens to actually better suit the immunogenicity. Of course, we have the need more safety data. On other part, we have the low-flow kind of the discovery of biomarkers that predict the benefit of immunotherapy, such as the use of component resolved diagnosis, basal activation tests, and other biomarkers that allow us to better predict which patient will respond to AIT. So these are some of the biomarkers. So we have the biomarkers that predict the response to AIT in terms of enrichment biomarkers, such as the eosinophils in asthma. We have the periostin level. We have also biomarkers that actually have the early predictors, such as the mast cells and basophils. And then late predictors like the IgA and serum levels of the different co-stimulatory molecules and IgE. And we have the biomarkers that predict the AIT failure, such as the high Th2 cytokines, such as IL-33 and IL-4 and CD38. These are sort of predictors of the likelihood that they fail the immunotherapy. A new kind of approach would be a combination of AIT and biologics. So combining the previous lecture by Fanny and my lecture. So some patients may be on omalizumab or tezepelumab, and then they would start on immunotherapy. So this will be another new approach that some investigators are studying in the clinical trials. With this, these are conclusions, right? So just to highlight that both subcutaneous and sublingual immunotherapy are effective. And treatment decisions should be individualized to balance the efficacy, safety, and adherence. So this, I end my presentation. Well, thank you for attending this first session. So welcome any questions.